Hello, everyone. Thank you very much for joining us for tonight's Icon Facebook Live on cervical cancer. Very much apologise that we've had some technical issues and are coming to you a bit late, but it's hopefully it'll still be a really great meeting. Very much want your questions and interactions, and that's the beauty of this Facebook Live series. This, I think, is the fifth in our series that Icon Cancer Centres are doing with the goal of educating um, patients, the community, caregivers about various types of cancers. Icon Cancer Centres have now 32 cancer centres across the 6 states. Our goal is to offer personalised care to as many patients as possible, as close to home as possible. Being diagnosed with cancer is always very stressful, and it's absolutely yet another stress to have to travel long distances to access care. So it's our mission to put up cancer centres in as many locations as we can so patients can have personalised and quality cancer care as close to home as possible. It's my great privilege to be Icon Group's medical director. I'm a practicing haematologist, so I don't treat cervical cancer myself, and that's why I have my very esteemed colleague, Dr. Jeff Go, with me tonight, who's going to very much lead our presentation and discussion around cervical cancer. For the first half of the evening, I'll be talking to Jeff and really picking his brains about all he knows about cervical cancer. And for the second half of our evening, we'll answer your questions. Please put them through the Facebook Live portal, and we'll try to get to as many questions as we can throughout the evening so that we can hopefully make it as educational and as entertaining as possible for you. Now, Dr. Jeff Go is a consultant medical oncologist at Icon Cancer Centres in Chermside and Greenslopes. He's also a senior staff specialist at Royal Brisbane and Women's Hospital. He treats a broad range of cancer types, but has a specific interest in gynecological cancer, ovarian cancer, and cervical cancer in particular. At present, Jeff is the chair of the Australia and New Zealand Gynecological Oncology Group's Cervical Cancer Working Party. So really, we have no better person qualified in Queensland to talk to us tonight about cervical cancer. So, Jeff, welcome and thank you.
Thanks, Ian. Thanks for the kind introduction, and certainly very happy to share my knowledge about cervical cancer.
Okay. Well, I think let's go into the talk then. Can you just tell us, firstly, Jeff, for those of us like myself who practice in different areas of medicine or people watching, tell us a bit about what is cervical cancer and how is it treated?
So, cervical cancer is a cancer of the lower female genital tract. Basically, it is attached to the uterus, and so it is mostly treated with chemotherapy and radiation. However, there are early cervical cancers in stage 1, for instance, which are treated with surgery, and precancerous lesions called CIN, cervical intraepithelial neoplasia, which is treated with surgery as well.
Sure. So tell me, cervical cancer mainly squamous cell carcinoma or
So the majority of cervical cancer is squamous cell carcinoma. I would say it consists of approximately 85% of cervical cancers. However, there's a small subgroup which are adenocarcinoma, which resemble cells from higher up in the female genital tract. But the uterine cancer also presents with adenocarcinoma. So a small minority, or about 15-20%, are adenocarcinoma. There are also rare types of cervical cancer that behaves like a more aggressive lung cancer called small cell cervical cancer. That is exceedingly uncommon. In some Asian countries like Korea or Japan, carcinoma is actually more common than what we have in Australia. So it may be about 25-30% rather than the sort of 15%.
Is the reasons for that known, Jeff? That's an interesting fact.
Well, it could be genetic and racial reasons. I don't think there's an etiological reason uh, that I know of. Cervical cancer in Australia is mainly driven by uh, HPV or human papillomavirus uh, infection, if you like, at an early age. So that's the main driver for the formation of cervical cancer.
Right. Okay. And HPV virus drives both squamous cell carcinoma and adenocarcinoma of the cervix.
I believe so. I believe that it's the main driver uh, for cervical cancer. In Australia, two main drivers for cervical cancer is HPV 16 and 18 subtypes. Uh, the HPV 6 and 11 subtypes actually drive genital warts. So there's slight differences, but 16 and 18 is the number that we focus on.
Right. And I think that'll become very important later on in our discussion when we go on to talk about the HPV vaccination. But no, thanks for clarifying that histological definition. I mean, I remember from my pathology days at university about cervical cancer and really it being squamous cell carcinoma. But hearing that there is a proportion of cervical cancer that is adeno cancer, I think is very interesting and hearing about the overseas experience. So thanks, Jeff. Can we just delve into a little bit uh, about the actual treatment? You mentioned that early stages of the disease, if it's picked up early enough, it's treated with surgery. Perhaps you could tell us a little bit about what sort of surgery, but then also, secondly, in the later stages, stages 2, 3, and 4, there's chemotherapy and radiotherapy. Perhaps you could tell us a little bit about the specifics of the chemotherapy and the radiotherapy across the stages.
So early cervical cancer, which I would say stage 1 to stage 1B1, where tumors are less than 4 centimeters, relatively small, can be treated with surgery. If it's small, surgeons usually, the gynecologists usually do what we call a cone biopsy, and there's various techniques of removing the tumor. Sometimes if the tumor is larger, they may do a hysterectomy if fertility is not required anymore. So in general, there is localized surgery such as cone biopsy to using other sort of tools such as to remove the tumor locally, or sometimes it requires hysterectomy, which involves removal of the uterus as well as the cervix. Once the tumor gets larger, such as above 4 centimeters, then surgery alone may not be sufficient because the surgeons may not be able to remove the entire tumor. And sometimes even removing the tumor would leave some tumor behind, what we call positive margins. In that situation, chemoradiation is still required to sterilize the area and in order to eradicate tumor completely. So in stage 1B, a large stage 1B tumors and above, surgery is usually not recommended, and we would go directly to chemoradiation therapy. Mm-hmm. So chemotherapy is actually a partner to radiation therapy, which is the most important component of the treatment. The chemotherapy consists of a drug called cisplatin, which is given weekly with external beam radiotherapy, followed by internal radiation called brachytherapy a week or two after the completion of external radiotherapy.
Sure. The weekly cisplatin, just to delve into that in a little bit more detail, can you tell us a little bit about how many weeks of the cisplatin on average, patients are treated with cervical cancer, and then just detail some of the side effects of cisplatin? It's actually an old chemotherapy drug, isn't it? I mean, it's been around for many years.
Yes, it's cisplatin or platinum-based therapy is very effective in cervical cancer. cervical cancer. Uh, the dose we use is not a high dose; it's an intermediate to low dose that is used as a radiosensitizer, makes radiation work better. We do know that cisplatin actually improves long-term curability uh, in addition to radiation. So it improves the 5-year cure rate by about 6 to 7%. So it is actually a very important part of radiation therapy. So radiation is still by far the most important part of the treatment, but I think the cisplatin adds that 6 to 7% cure rate.
Does it add many side effects? What are the side effects of cisplatin, Jeff?
At that dose, it causes very little side effects. We can manage nausea very well. So nausea is not a major issue anymore. It can, however, cause things like ringing of the ears or tinnitus. It can cause renal dysfunction or dehydration potentially. So we actually hydrate patients with saline before and after cisplatin, and even top patients up with electrolytes to minimize any hypokalemia or low potassium and low magnesium. So we do actually do hydrate patients before and after cisplatin chemotherapy. So the toxicity is actually quite little. There's overlapping toxicity with radiation, such as nausea, which we can deal with stronger antiemetics like ondansetron.
Sure. On average, if a lady is having radiation therapy for cervical cancer, how many treatments or fractions, as I guess each treatment of radiotherapy is generally referred to as, how many fractions are required?
So about 25 fractions given over a period of 4 weeks or thereabouts. The sort of total external beam dose is around about 45 grays, but the internal dose is also around about the 40-45 grays. So the total dosage, if you like, external plus internal, is about 80 to 90 grays.
Right, given over that 5 to 6 week period.
Correct. Yeah, the internal radiation or brachytherapy is given over usually a weekend.
Right. Okay. No, that's been very illuminating, and I think we have already had some questions come in from various audience members, and some questions. One I think is probably worth even just going to now, even though we aren't quite in the question part, but I'll jump to it now, and then we'll come back to questions in the second half of the talk. But Amy and June have both emailed in asking, is immunotherapy efficacious in treating cervical cancer? And if you could explain a little bit about what actually immunotherapy is.
So I'll take one step back before the immunotherapy question. So there are trials that are maturing at the moment asking the question of whether further chemotherapy after chemoradiation will improve survival. So there is one trial which has suggested that further 2 cycles of chemotherapy after chemoradiation may improve survival, but we're waiting for a bigger trial called the Outback trial. It's an Australian trial run internationally to answer the question of whether further chemotherapy after chemoradiation will improve survival. So that's the first point. The second point about immunotherapy, immunotherapy works by activating the patient's T cells to attack the cervical cancer. Uh, so it's a drug actually called a PD-1 or a PD-L1 inhibitor that sort of stimulates the patient's immune system. We are doing a trial at Royal Brisbane Women's Hospital of chemoradiotherapy with or without a drug called pembrolizumab or Keytruda. So that trial is ongoing at the moment, and we're actively recruiting patients who are stage 3 to 4 and no positive stage 1B and stage 2 disease to that trial. So if we are very interested to see if immunotherapy improves the cure rates for early to stage 4 cervical cancer.
Right. Does that trial have a catchy name like your Outback trial, Jeff?
No, it's called the Keynote A18. It's yeah, I don't know why it's called A18, but
Right. So both the Outback trial and the trial that you describe of immunotherapy, we don't know the results yet. That's what you're saying.
yeah, the Outback trial was designed by one of my colleagues from Peter MacCallum Cancer Centre, Linda Mleczkin, many years ago, but we're still waiting for the results to mature. The trial has completed a few years ago now, but that may reach practice in due course. But the immunotherapy trial is also very exciting, and that's just started. So the results would not be available for another 4 to 5 years, unfortunately.
And certainly jump in, correct me any time, Jeff, if I say something that you disagree with. But I think, just editorialising there, certainly COVID-19 has very much taught us that it's important to wait until trials are completed, to wait until the evidence is in before you change treatments. And you'd already explained at the start that for early stage cervical cancer, surgical treatment is often curative. For later stages of the disease, chemoradiation therapy is the preferred treatment. And these trial approaches of adding extra chemotherapy or adding immunotherapy onto chemotherapy are just that. At the moment, they're hypotheses, they're unproven, and we shouldn't change our treatment paradigms on these wings. We need to wait for the trials. COVID-19 has shown us that to jump in with unproven therapies, such as hydroxychloroquine for COVID-19, convalescent plasma, it is actually harmful and does not help.
So I would agree. And most of the major guidelines in Europe and America have recommended chemoradiotherapy as a standard treatment, and clinical trials remains what it is, experimental treatment. I strongly encourage patients to participate in clinical trials because I believe that it will advance the science of treating cervical cancer and potentially improve cure rates and change practice in the future. So I do encourage participation in trials.
Absolutely, and couldn't agree more. It's certainly, as part of Icon Cancer Centre's through Icon Research, we are running a number of trials, and it's been a focus of the federal government, with the minister announcing in the recent past large sums of money to support clinical trials, teletrials in oncology as well as other areas of medicine. COVID-19 not only has taught us not to use unproven therapies and be careful about doing the right studies, but it's brought back many other adages to the fore that we used to hear. And one of them that comes to mind to me is that prevention is better than cure. And I think cervical cancer, nowhere is it more opposite to go by the aphorism of prevention is better than cure in cervical cancer. So clearly, you've already said there is a pre-malignant stage where you have CIN going into cervical cancer, and before CIN, there are, as you'd explained to us, Jeff, various strains of HPV or human papillomavirus that actually trigger and cause CIN to go and then the cervical cancer. Can you outline to us then some of the recent developments along uh, vaccination against HPV and how that prevents against cervical cancer, and then also how the pap smear has changed because no longer do women have a traditional pap smear, but there are much better ways of detecting the early stages of CIN cervical cancer.
Thanks. So the vaccine that was first discovered in Australia by Professor Ian Fraser is called Gardasil. So he won a lot of awards for uh, being able to manufacture this vaccine, which is now widely available for school-age kids who are, reaching puberty before they become sexually active. So the vaccine that is widely used in schools is called Gardasil 9, which covers 9 different subtypes of HPV virus. The most pathogenic types of the virus type 16 and 18, which was covered by an earlier version of the virus called the quadrivalent vaccine, and a version before that called the bivalent vaccine. If given before the uh, school age children reach sexual maturity, the protection is 97% in terms of preventing CIN or early cervical cancer. Uh, but once if it's given to a broad population, the protection is only 44%. So it's better to give vaccine to kids before they're exposed to the HPV virus. Um, the second question about uh, the pap smear. So prior to 2017, pap smear is done, and usually the lab would look for abnormal cervical cancer cells for early signs of cancer. But as of 2017, they have moved towards testing for HPV DNA. So the test is a lot more accurate at picking up any changes early on. So it is done similarly to a pap smear that the GP or the doctor will still have to actually get a sample from the cervix. However, the test in the lab is completely different. It's a DNA test and it's more accurate. So it's only done once every 5 years now, which is a great win for women.
Mm.
Yeah.
Mm. Excellent. The Gardasil HPV vaccine, Jeff, does it have any side effects?
Most studies have described injection site irritation and erythema or redness, which is short term. But that's the most common side effects, and I think it has been proven to be very safe. And there's a lot of women who've had the vaccine over the course of the clinical trial development. I think over 50,000 women, and it is shown to be very safe. It's usually local reactions that people get.
So a little bit of redness around where you have an injection, which is really, I guess, to be expected. I
Hmm.
would have thought, but you're saying there are no, particular good medical reasons or scientific reasons that people need to be afraid of this vaccine or spreading any rumours or negative publicity against this vaccine. Then it's a
No, it's to a point where it is now offered in most schools in Australia. Unfortunately, it is not universally available throughout the world, but in most Western countries, I believe it's offered in most schools to kids aged between 13 and 14.
right. Yes. No, I just back up everything you're saying there, Jeff. I mean, it's just a fantastic uh, invention, the Gardasil vaccine, and for it to be developed right here at Brisbane, from Ian Fraser, and I think probably you, like me, Jeff, can remember being lectured by Ian in medical school many years ago now. It's just a fantastic achievement from Professor Fraser, and absolute, you know, game-changing discovery that has helped women and men throughout the world. You mentioned about, unfortunately, the vaccine is not available around the world. Now, obviously, we can't travel around the world at the moment, but perhaps you could take us on a little bit of a journey around the world and tell us what happens with cervical cancer around the globe. What are the various different incident rates in different countries and continents? And are there any differences in the way cervical cancer is treated in different countries?
Look, I would say that globally, cervical cancer is the fourth most common cancer in women, but in Australia, it's the 13th most common. So, in third countries such as South America and parts of India, where radiotherapy is not widely available, uh, the outcome is much poorer, and therefore potentially chemotherapy and surgery is used much more frequently. So radiotherapy requires vast infrastructure spending and also technicians to actually run it specialized radiation oncologists to actually map the treatment plan. So it is not easily available in third world countries. So therefore, the treatment is suboptimal in those countries, unfortunately.
Right. Okay. Which is yeah, it's very sad. It's very difficult, and again, it's interesting you point out the different incidents across different countries, and hopefully, as medical care improves in these countries around the globe, that um, rates of survival cancer will reduce as they have in the first world. Now that's been fantastic, Jeff. That's been really a whirlwind half an hour tour at survival cancer. And certainly I've learned an enormous amount. We're going to go on to the second half of the evening now, where we answer your questions. We've already got quite a few coming in. We've had a few pre-registered and a few more tonight. So please, through the Facebook Live channels, ask questions. We very much want to make this an interactive session and be about experts like Jeff educating us all. You answered a couple of questions about immunotherapy earlier on, and we've had another question about immunotherapy following on from what you said. That is Claire asking whether pembrolizumab, which is known as Keytruda, or another checkpoint inhibitor, will be ever approved for cervical carcinoma in Australia, as it is in the US.
So, Claire, thanks for the question. I guess stage 4 recurrent cervix cancer is a difficult disease to treat. And there's also a question from Kim about her mum having stage 4 cervical cancer. So I would try and encompass those questions in one. So Keytruda has recently been licensed in America for treatment of advanced or recurrent cervical cancer once patients have progressed on standard chemotherapy and Avastin. So the first point I'm trying to make is that for patients with recurrent cervical cancer, the first line treatment is platinum-based chemotherapy with paclitaxel and an antibody Avastin or bevacizumab. That is the first line treatment that we use here in North America, and it is quite effective with a response rate of approximately 50%. So that's the first point I will make. The second point is Keytruda works afterwards, and the response rate is based on a phase 2 trial that led to the FDA approval of the drug in America. And the response rate is still quite modest at 15% for all comers. And if they had a protein or marker called PD-L1 positivity, then the response rates are higher, about 30% or thereabouts. So immunotherapy is still in its early phase, infancy phase in treatment of advanced cervical cancer. So the answer is, I think if I had a crystal ball, I think the combination of chemotherapy and immunotherapy may actually work better, and there are trials exploring those possibilities and would be reporting in the next year or two. So I think the combination of chemotherapy may become a standard in recurrent metastatic disease.
So, Jeff, the trial you'd mentioned before that you were conducting of chemotherapy plus immunotherapy, that was more towards the start together with radiation, and where the approvals in the US, but not Australia, are for more advanced recurrent disease. Is that the difference?
That's correct. So the approval in the US is for incurable metastatic disease or recurrent disease. And in that situation, I think it is fair because patients do, need a better treatment than second or third line chemotherapy. And Keytruda in general has very favorable toxicity profile.
Okay. Well, that is a fantastic segue into the next question. It's from Angela, which what are the side effects of Keytruda? Right. I guess really the question is, what are the side effects of or immunotherapy drugs. And Angela goes on to ask, are these immunotherapy drugs like Keytruda better or worse than chemo?
So to answer your question, I'll take a broad approach. Keytruda stimulates the body's T cells to attack the cancer, but there are bystander effects that the T cells may attack the body itself. The more common side effects are skin rash and thyroid dysfunction are the most common side effects, but it can also attack any other organs in the body, like the liver or the lungs. Uh, Fortunately, the severe liver, lung, cardiac toxicities are actually less frequent. In a lot of drugs, in melanoma, lung cancer, as well as kidney cancer, the quality of life of those patients having immunotherapy is better than traditional targeted treatment or chemotherapy. So, in general, single agent immunotherapy is certainly better tolerated than chemotherapy overall. But that's just a general statement. Obviously, immunotherapy can come in different forms, and we're combining different immunotherapy drugs. And if you combine different immunotherapy drugs, the side effects become great.
Okay. Now, that's very useful. And certainly, I guess the message is, as you explained very nicely, that immunotherapy is not free of side effects.
The other problem with immunotherapy is that it's only funded for a number of cancers, but not all cancers. So, for if there is no funding from the government, the cost is quite exorbitant at the moment.
Sure. Okay, last sort of question on chemotherapy before we change tack to some of the other questions. But Michelle has asked, would treatment be as effective if carboplatin is being replaced at weeks 4 and 5? So you mentioned the use of cisplatin together with radiation therapy. Could you explain a little bit about if or when carboplatin is substituted for cisplatin when they two?
So, cisplatin is the backbone of chemotherapy, and there have been trials showing that cisplatin is slightly better than carboplatin. So, I would really use carboplatin with radiation if there was a contraindication to cisplatin, for instance, abnormal kidney function, which I think would not tolerate cisplatin. So, just contraindication, I would use carboplatin as a substitute.
Right. Okay. No, very. And Kate has a question related to surgery. This uh, uh, I very much research, Jeff, with your knowledge of cervical cancer. In early stage cervical cancer, what is the difference between a cone biopsy and a hysterectomy? And in particular, is the rate of recurrence after a cone biopsy less or equivalent to the rate of recurrence after a hysterectomy?
I can't be more specific about it, except to say that a cone biopsy is for a much smaller tumor and a hysterectomy is for a bigger tumor, up to 4 centimeters per 10. Uh, Obviously, with bigger tumor, cone biopsy is not feasible because you'd have positive margins. So that's more a question for a gynecologist who does those surgeries every day. So in my novice type experience, I think the hysterectomy is reserved for bigger tumors.
Right. Sure. Now, for people undergoing treatment for cervical cancer, whether it's radiotherapy or chemotherapy or chemoradiotherapy, um, what sort of diet should people follow? We and we I sympathise. I know as a practicing haematologist that whenever a person is diagnosed with something, there are always well-wishing, well-meaning family members, friends who want to advise on diet or give the latest advice relating to a supplement, whether that be apricot kernels or raspberries, cranberries, etc. So, if someone's having treatment for cervical cancer, what advice do you give people, Jeff, about their diet? And are there any superfoods or supplements that people should take because it will help their treatment?
I would say that a balanced diet would be what I would recommend. Um, Towards the latter part of chemo radiation, diarrhea becomes a problem. So I guess I would recommend patients to avoid foods that can lead to diarrhea. Um, so anything that potentially can uh, cause a gastrointestinal infection, like cold seafoods or soft cheeses, I think may be best avoided towards the end of the treatment when diarrhea becomes a problem. But overall, I would still want patients to maintain, a nutritional state which is compatible with, getting a treatment and healing. So, if there was any uncertainties, I would certainly refer my patients to a dietitian for a discussion. But really, I think a healthy, balanced diet would be important. There is really no evidence that apricot high vitamin C infusions actually improve the outcome, but it may actually interact with the treatment and cause toxicity. So I would be very cautious about those extra supplements.
Sure. Okay. We're coming on towards 8 o'clock. So, last question, and that is after having treatment for cervical cancer with chemoradiotherapy, is it worth having the Gardasil vaccine?
Look, I think the HPV DNA has already caused cancer. I'm not sure if having the HPV vaccine at that point improves the cure rates. The short answer to that is that I don't know, but scientifically, I don't think it will improve cure rate, the long-term cure rate of treated cervical cancer.
Sure. No, thank you, Jeff. As I said, I think uh, it's probably time to wrap up. I realise we've been having a few sound issues during the night. Very much we apologise for that. Technology uh, is never able to be controlled 100%. We truly apologise for that. We'll try and very much rectify it. We will have a recording of tonight's question and answer as well as Jeff talk on our website. Icon Cancer Centre's website is being developed with a view to increase week by week the amount of educational material there to make sure the material is from reputable sources and is of high quality. So tonight's presentation will be on the Icon Cancer Centre website and hopefully the audio will be resolved. It just then behoves me to wrap up and to once again thank Jeff for his time. I also thank the Australian Cervical Cancer Foundation. This is Cervical Cancer Awareness Week. It's a very important week because, as we've heard throughout the night, cervical cancer very much can be prevented. And prevention is all about awareness. It's about public health measures. It's about all of us taking responsibility for ourselves and our loved ones, ensuring we get vaccinated, ensuring we get screened. But so very much pay tribute to the Australian Cervical Cancer Foundation and the great work that they do. Also, our technical team at ICOM, thank you. It's always a pleasure to host these events with our many ICOM specialists. I always learn a lot. And please, if you ever have any questions, you can always put them in through the website and our team will endeavour to answer them. So have a good evening. And if you're watching this event later on, thank you for tuning in for tonight's talk on cervical cancer with Dr. Jeff Gardner.
Thank you for listening and happy to answer further questions on